Dr. Grubbs is an associate professor in the Division of Nephrology at the University of California, San Francisco, and she's maintained a clinical practice and research program at Zuckerberg San Francisco General Hospital since 2009. She received her undergraduate medical degrees from Duke and master's in public health at UC Berkeley. After a primary care internal medicine residency at Highland Hospital in Oakland, California, she went on to complete fellowships in general medicine and general medicine clinical research and nephrology at UCSF. Her research focuses on palliative care for patients with end-stage kidney disease. She is among the 2017 cohort for the Cambia Health Foundation Sojourn Scholar Leadership Program. This is an initiative designed to identify, cultivate, and advance the next generation of palliative care leaders. And we are really glad that we have a nephrologist who's also identified among the next generation of palliative care leaders. And we actually have several other coalition members who've also are in this same leadership program. She also has received an award from the 2018 California Healthcare Foundation's Healthcare Leadership Program. Her clinical and research work fuel her passion for creative writing. Her first book, Hundreds of Interlaced Fingers, A Kidney Doctor's Search for the Perfect Match, was released in June of 2017 from HarperCollins Publishers Amistad Division, and it's now in paperback. She lives in Oakland, California with her husband and 3 of the cutest rescue dogs that help ease the empty nest pangs her teenage son left when he went off to college. So, Dr. Grubbs, we really appreciate this bio sketch of you, and we're turning it over to you, and we look forward to your presentation. Thank you very much.
Thank you so much. I just want to say first, thank you for inviting me to give this webinar, and thank you for everyone who is participating. Woody, I'll depend on you to just jump in if there's questions, because now that I have my PowerPoint open, I'm not able to see when questions come in.
Sure.
So as Woody already mentioned, this is my disclosure of my book. And these are the things that I'm hoping to accomplish in the next hour. So I want to describe the current dialysis population and how we usually take care of particularly older patients with end-stage renal disease, and then talk about alternative paths to the usual care and understand when we should think about implementing these alternative paths and what the barriers to them might be. I want to start with a story of why I do this work. And when I talk to primarily a nephrologist audience, I tend to just let you know that I will be giving some p-values and percentages soon, so just bear with me for this story. I'm reading from my book, and just a little warning, this is about 5.5 minutes long. And this is from chapter 18 in the book called 3 Ladies. Not long after I joined the faculty at San Francisco General Hospital, I met 83-year-old Ming Lee in the pre-dialysis clinic, where I served as the attending nephrologist when my colleague was unavailable. Just a few months prior, my colleague was one of my attendings and had a good 3 decades of nephrology experience over me. So I tended to not change the care plans already underway for patients returning to the clinic. Mrs. Lee's plump face was constantly smiling. Okay, thank you, doctor. These were the only English words, usually strung together, I ever heard her say. A Cantonese interpreter translated the rest, and her granddaughter sat silently beside her. Mrs. Lee had a GFR of 16 milliliters per minute, only about 3 teaspoons of blood coursing through her kidneys filters each minute, when normal for her age is closer to 17 teaspoons. She also had an extensive list of other medical problems, blockage in her heart arteries, mini strokes, gout, and a recent bowel obstruction, just to name a few. She was scheduled to see a vascular surgeon the following week to talk about creating a fistula for hemodialysis, but she was ambivalent about going to that appointment and about dialysis in general. I was ambivalent too. The plan for Mrs. Lee felt wrong. Given her age and overall health status, I didn't think dialysis was the right thing to do. As a fellow in the pre-dialysis clinic, what I observed for how to have discussions with patients approaching end-stage kidney disease seemed consistent with the monolithic, unquestioning agenda implied by the clinic name. The response to patient hesitation towards dialysis or outright refusal of it often felt threatening, coercive, even bullying to me. Start dialysis or you'll be dead in 2 weeks. You have a responsibility to your grandchildren to be here. If you refuse to start dialysis, then you will be discharged from this clinic. These were the refrains left in my mind. I was determined not to repeat them. I was no longer the fellow just doing what I was told to do, saying what I was told to say. My actions were my own. My words were my own. I tried something different with Mrs. Lee that day. Not everybody chooses to start dialysis, I said delicately, tiptoeing into a conversation about the possibility of another course. But before the interpreter could say my words in Cantonese, I watched the granddaughter shift in her seat and the cross of her arms tighten. Though she hadn't spoken a word, it was clear that she understood English and that she didn't like what I was saying. I didn't know how to move Mrs. Lee off the path she was on without making her or her family feel that I was denying her care or sentencing her to death. I didn't know what a different path would bring. I retreated. Well, maybe you should just go to the appointment and hear what the surgeon has to say, and then decide if you want to go forward with it, I said. With these words, the granddaughter's posture softened, and Mrs. Lee smiled and nodded. Okay, thank you, doctor. 5 months and 2 surgeries later, I saw Mrs. Lee in clinic again. She had a fistula buzzing in her left upper arm, and I said nothing to suggest she consider a path that did not involve dialysis. Another year had passed when I learned that her kidneys had failed to the point that my colleague thought starting dialysis was appropriate. Her fistula was ready to use. She started dialysis with a Cantonese-speaking nephrologist in a Chinatown dialysis unit. Oh, good, I thought when I heard the news. She would be with people who spoke her language, a community who understood her experience. A few months later, I walked into our renal center administrative office. I checked my mailbox. I signed off on orders for a new patient's peritoneal dialysis supplies. I chatted with office staff like any other day. Do you remember the patient Ming Li? Asked Bao, the office administrator. Chinese-American Bao was a dialysis technician before joining the business office. She sometimes worked as a dialysis technician at local dialysis units, both to help out and to keep her skills sharp. Yes, of course. How is she doing? I asked brightly. She jumped off the roof of her 5-story apartment building. She jumped off the roof. The words hit me in the chest so hard they took my breath away. I imagined how unheard she must have felt, even in Cantonese, how dark her world must have been with no sign that the sun would shine ever again. Maybe she jumped off that roof because of something completely unrelated to dialysis, but maybe it was all about dialysis and she saw no other way out. And I didn't have the training, the words, the courage to show her there was. I tried not to cry. So, as that passage suggests, what I was taught, and I know many around the country have been taught similarly, once you have end-stage kidney disease, your options are dialysis, transplant, and death. And for the older population, it's mostly dialysis or death. And particularly in the U.S., I think it's a particular issue because of this quote best expressed by Ian Morrison, a healthcare futurist, where he says, in England, people believe death is imminent. In Canada, people believe death is inevitable. But in America, people believe death is optional. So, and I say this just to make the point that eventually everybody dies, and the time to death may not be different depending on the patient's individual characteristics. So I wanted to kick off one of the audience response questions. Which of the following factors may suggest no survival difference between starting dialysis and foregoing dialysis? The answers: A, age greater than 75 years, B, dementia, C, ischemic heart disease, D, all of the above, or E, none of the above. If we could start the timer and give folks about 30 seconds, unless all the responses are recorded sooner. So I can't tell if responses are in, so I'll just go on. The answer is D, all of the above, and I'll go into some more detail. So this is one of the more one of the better studies that we've had to kind of drive this point home. This is out of the United Kingdom, where most of the work in this area comes from. This one provided 18 years of follow-up and included a little over 800 patients. Things that I do want to point out is that in the dialysis group, the mean age is a lot lower than the mean age in the conservative management foregoing dialysis group, and the bulk were over 75, and that there was a much greater percentage of high comorbidity in the conservative management group. But then it does show that dialysis did offer a survival advantage compared to conservative care, but this didn't hold if the patients were old and sick. So what this slide shows is a separation between the low comorbidity and the high comorbidity group.
Dr. Grubbs, I just want to report the results of the polling. 45% answered D, all of the above.
Great. So from this slide, after adjusting for age and comorbidity, there was a 4-month survival advantage, but that wasn't statistically significant. And most of the time that is gained is often spent at dialysis or in the hospital. This is from Carson and others published in CJSN in 2009. And what it shows is that in the supportive care group versus a hemodialysis group, there was a pretty significant difference in survival, but as you can see in blue, there wasn't that much difference between the hospital-free days. And what this doesn't take into account that I think that is captured in this other study by Montez Rath and others published in Journal of General Internal Medicine in 2017 is actually the days spent in a nursing facility. So this is a national U.S. study of a little over 28,000 patients over the age of 67. And what they're depicting here is heat maps as a different way of showing where patients spend their time. And so what you can see here is that all the gray is where people are at home, and this one is specifically broken down by age and whether or not patients have cardiovascular disease. Hospital days are in red and nursing facility days in orange. And they show where people started dialysis, and they have data between, from a year before and a year after. And what I want to point out here is this is the younger age group, 67 to 70, without or with cardiovascular disease, and you can just offhand see the difference between how much more time is spent in the hospital and nursing home versus for people who do have cardiovascular disease versus those who don't. It's not that different for folks who are over 80 comparing with the younger group, but sorry, this is very sensitive. As you can see, the over 80 group with cardiovascular disease, there's a lot more red and orange, and it extends much higher than those who don't have cardiovascular disease. This is even more pronounced among folks who had dementia, even in the younger group. So 67 to 70-year-olds at the top here in panel B with dementia, and A without dementia versus those who are over 80 without and with dementia. A couple things I just want to point out. As you can see in panel D here, only 2% had no facility days. And here you're seeing some people spent all their time in the hospital or in nursing facilities. And we also know that most of our frail patients will decline soon after starting dialysis. This study by Tamura and colleagues published in the New England Journal of Medicine in 2009 is a study of 3,700 nursing home residents who started dialysis between 98 and 2000, and it plots the percent residents in months since starting dialysis who died, had functional status decreased, or had functional status maintained. And what I want to point out is just at 3 months after initiating dialysis, 50% either died or had a decrease in their functional status, suggesting that for the majority, we're not really doing people, at least frail patients, a favor by starting dialysis. Also from Tamura and Kidney International in 2012, what this figure nicely depicts is that what we can expect in terms of life expectancy based upon frailty. It shows all the different age groups by the life expectancy in years, and as you can see, for people over 75 in the most frail group, 25th percentile, they can only expect to survive on average 6 months after starting dialysis. Now, in terms of who is frail, what the authors suggest in this paper is it's more of an eyeball test in terms of we can pretty much tell who are extra spry, playing tennis 75-year-olds versus those who spend most of their time in a wheelchair, for example, as being the most frail. So what are the various paths? So we have what we usually do, time-limited trials. I'll talk a bit about foregoing withdrawing dialysis, as well as what we've described as a palliative approach to dialysis care. So starting with the usual, it's usually an one-size-fits-all type of approach with in-center hemodialysis 3 times a week, 4 hours. Put just fistula first, mantra. It's all about kinetics, diet restrictions, and on average, people in this country start dialysis at a GFR of 10 mils per minute, and involves a lot of intensive care. This is in spite of our very much changing demographic in the U.S. In 1967, only 7% of patients on dialysis were over 55. And end-stage kidney disease was really their only problem. So the goal was not just about survival, but also rehabilitation, like getting people back to work. But in this, the data from 2011, over half of the population was over 62, and the prevalence of folks who were older had doubled over the last couple of decades. Sorry if you guys are hearing beeping. It's trash day where I am. And also people had a lot of comorbid conditions, very high morbidity and mortality, so that the real goal was just about survival rather than hoping for people to get back to work. This study by Wong and al. Published in CJASN a couple years ago really shows how the U.S. is really different than other similar countries. And just pointing out in black is the U.S., where the authors examined a cohort of more than 28,000 adults in the VA system who had a GFR of less than 15 between 2000 and 2009. And they linked data with the Medicare and the U.S. renal data system to identify people who received dialysis during the follow-up through 2011, and that was a little over 19,000 people. They also conducted an in-depth review of chart notes to determine the treatment status among a random 25% sample of the 9,400 who had not initiated dialysis. So I want to point out here that in the black, this is the study, and particularly for people in the older age groups compared to folks in Canada or Australia and New Zealand. We tend to start a lot more people on dialysis, even regardless of the level of comorbidity. This is from the same study from their chart review, where they went through to determine who had actually made a decision against starting dialysis, people who were discussing and are preparing for dialysis, and we already know from the prior slide those who have received dialysis or enrolled in the other data systems. And what I want to point out is that this just shows the older age group and comparing low comorbidity to high comorbidity. In the oldest group, 44% had made a decision against dialysis, and in the low group, but in the high group, that was just 48%. So not that much different. And our usual practice is that pretty much everybody starts in-center hemodialysis with, of course, just this tiny slither that are well enough to have a transplant, and about 6% who undergo peritoneal dialysis. And the older patients get much more intensive care in the final month of life compared to patients who have cancer or heart failure. This is another study from the Wong group and O'Hare's group, where they looked at nearly 100,000 Medicare beneficiaries over the age of 65 in 2004 to 2007 who started dialysis up until 2009, and just pointing out that folks with dialysis had more hospital admission, more ICU admission, more death in the hospital than cancer and heart failure patients, but much less use of hospice. And this is particularly concerning since it's not really congruent with patient wishes. Even in a U.S. study from Hines in 2001, dialysis patients, only 18% of them preferred to prolong life, even if they were suffering. And so we have this intensive pattern of care and tend to lack appropriate addressing of symptoms, even though we know that patients have a similar symptom burden. This is a project that I led along with Steve Panelat of a data set from the Palliative Care Quality Network. It included 54 palliative care teams, 38 of them reported patient-level data in 11 states. And this represents over 33,000 patients who were hospitalized and received a palliative care consultation between 2012 and 2016. a little over 3% had renal disease. So what this really shows is that the people with renal disease versus other serious illnesses had very similar symptoms in terms of pain, anxiety, nausea. Dyspnea was much more common in the other serious illness group. And this Palliative Performance Scale, the PPS, was very similar as well. And for those not familiar with that, that's scored on a scale of like 0 to 100% in terms of people's ability to ambulate, the activity level of their disease, how well they're able to take care of themselves, level of consciousness, and how well they can take in oral. So, and for a little bit of context, people with a score of 50% spend more than half of their time sitting or lying and need a lot of assistance with their self-care. And so for those with a score of 30%, they are completely bed-bound, have reduced intake, and require full assistance for care. So this is where most of the patients in this study were. So in terms of talking about a time-limited trial, next question, which of the following would you say is an appropriate length of a time-limited trial of in-center hemodialysis? I'm going to go ahead and start the poll. And you have about 30 seconds to answer. And Sharon, I'll leave you to jump in when, okay, we're at 30 seconds. And
yeah, right now we have 40% answering 1 month, 12 treatments. The next highest score is 20% at 6 months.
Okay, so the answer I chose is 1 month, and it's not really so much based upon any data. Frankly, when I was in training, it was pretty much described as, oh, you just say to people, let's give it a try, and then 6 months later, do you want to stop? And everyone says no. But that's not a realistic trial, given that you haven't really dealt with any of the patients, what they're hoping for from dialysis, the fears that they might have of what stopping dialysis would mean. So the description of a real-time limited trial comes from just interviews of people much more experienced than I am, who have put this into practice. And what they suggest is discussing the concept of what a time-limited trial means and what the prognosis for the patient would be with family meetings over 2 or 3 of them, and really defining what the goals are. Are we hoping to have just better symptoms, be able to participate more in what they enjoy? And then really limiting it to a month, because what you see at the end of the month that's what you're going to get. It's not going to really be any different. And then have weekly bedside or chairside family meetings to talk about progress. And I think this is particularly important because oftentimes we are interacting with families who never come in and see what the patient is actually enduring, or how they're to see how they're feeling, or they're halfway across the country and making decisions based not entirely upon the reality. Switching gears a little bit to foregoing and withdrawing dialysis. It's not so easy. So this is a list of things that I've pulled out to talk about what makes the idea of foregoing or stopping dialysis particularly difficult. Lack of training, time. We have financial incentives to dialyze folks. There's lots of uncertainty about prognosis, also in terms of both in terms of life expectancy as well as what being on dialysis would be like. And then we have issues with palliative care and hospice capacity. So I struggle a bit with us using training as an excuse, because we use that excuse, but we haven't really done anything differently, as these two studies show. And these are studies of graduating nephrology fellows across the U.S. In 2003 and 10 years later. And as you can see, when it comes to fellows saying that they've had a lot of teaching, 10 being best, they've had a lot of teaching of hemodialysis at both time points, a good amount for a distal renal tubular acidosis, but not so much when it comes to dealing with the end of life. And then when we get into the lack of time, it's very much tied to the money. This first bullet comes from a study from Erickson and others and C. Jason, published in 2013. And what they found is, and this is a national study, and they looked at geographic differences. And 69% of in-center hemodialysis patients had been seen at least 4 times in a month. And this had only been 15 to 36% prior to 2006. And it was after 2006 that the visits were incentivized. So the more we see the patients up to 4 visits, the more money we make. And less than 1% of the variation was explained by patient factors. So it wasn't that clinicians were just seeing the sickest patients most often. So one would think, or at least I think, that if we're seeing patients so many times, we ought to be able to address all the different issues that our patients have to deal with. But unfortunately, we don't have really any guidelines that specifically speak to advanced care planning or symptom management. So that means that we're left with it being essentially acceptable for us to have what I call drive-by visits, where, and I noticed this quite a bit when I was in training, and I can't say that I'm not always innocent of this myself, where you kind of go by the patient chair side, how you doing, write down the blood pressure, and maybe review a lab or two, and then move on without really getting into the day-to-day issues or burdens of the patients. And this other study by Harley, in the third bullet, published in Jason in 2013, it further underscores how our financial incentives push nephrologists to have large patient panels, large caseloads, and it may result in more income for the nephrologist or the group, but it doesn't result in better patient care. Patients who were in these large caseloads had higher mortality, lower dialysis adequacy, and less often received a kidney transplant compared to patients who were among smaller caseloads. And then the issue of uncertainty. What I'm showing you here from Cohen and others, published in C. Jason in 2010, is one of the more popular calculators that includes 5 different variables that are associated with early mortality. And I've just filled in this to show an example of what the calculator will kick out. And the problem that I have with these is that I don't think they could ever really be precise enough. And these numbers don't really mean that much to the person that is sitting in front of you. I mean, if you're sitting in front of somebody with this data and say, oh, in 6 months you have a 43% likelihood of still being with us. That's not very meaningful to the patient, particularly in terms of how they will be able to make a decision or their families help them with that decision. So one thing I'd like to present to you all is a different approach, and I'm a big promoter of it. I can't take credit for it, though. Gretchen Schwartz, a surgeon at the University of Wisconsin, is leading this effort that was originally started from Toby Campbell's group for surgeons to basically get the surgeons out of the habit of talking about statistics and really replace that with stories, so that patients could really, and their families could make an informed decision. There's a detailed account of how to use this on YouTube, but just going through it briefly, this is what it looks like. I describe it in an editorial published last year, and I've talked to Gretchen about how it's played out, as well as Kate Schuler, who is palliative care doc at University of Wisconsin as well. And what I really appreciate about this is that it allows us to talk about our exceptions. I've often heard people, they talk about, oh, well, I had this 90-year-old with heart failure, and once they started dialysis, they didn't go into the hospital anymore, and they did great. So we get to talk about that as the best case scenario, for example, but then we also have to talk about the worst case scenario, like what happens with most of the 90-year-olds. And so the way this tool would work is that as the nephrologist is talking about the two options, dialysis versus no dialysis, of course, both palliative care is appropriate for both. You talk about what it might look like and write it out. What might it look like in the best of circumstances, the worst of circumstances, but what's most likely for the particular patient in front of you for both options. So in my conversations with Gretchen and Kate, there has been a pilot with a small group of nephrologists at the University of Wisconsin. And the positive part of it is that they can do it, and they actually appreciate having the structure and framework. But many struggled with the notion of presenting no dialysis as a choice and not really understanding why, if dialysis could be beneficial, why would someone not have dialysis? And they also struggled with telling a richer story that included more of this kind of downstream things. I think we tend to start with, oh, if you're on dialysis, you might feel tired, you might have some cramping, but we don't talk about this, what happens more often, like you'll probably have more hospitalizations, you might live about a year. We tend to stop kind of, just what the actual symptoms of the of dialysis in this case would be. So I'm glad to report that Gretchen and I will be collaborating. We're collaborating on one of my ongoing projects where I'm basically chronicling the experiences of older patients with end-stage kidney disease who do and don't start dialysis with a mixed methods of collecting quantitative data, as well as semi-structured interviews of the patients and family members over the course of a year, and maybe I'll be able to continue it even longer with the intention of getting more substance for nephrologists to use when we talk to patients about what the downstream realities might really be for older patients who choose to start dialysis or choose to forgo dialysis and are conservatively managed. I think this is particularly important because most of the work we have doesn't really take into account what happens prior to starting, or unless people start dialysis, for example, because our U.S. renal data system, the ESRD, really only records people who start dialysis. We don't have any national database for people who never start dialysis. And this is where, even though the heat map data that I showed you earlier in the talk doesn't include this either, at least it does provide some of at least where people are up to a year before starting dialysis. And one of the things that I use in my own practice is this figure that I showed you earlier to help tell the story of what people might be able to expect. And I've used this even for patients who are younger than the 65-year-old age group, because I come across quite a few people who they have these strange assumptions about dialysis, like it's only going to give them, a few weeks of added life. And I've used this to point out, so for you, you're in pretty good health other than this kidney failure, so I would put you in the 75th percentile. You're only, 62, but even if you were a little older, on average, I would expect you to have at least another 5 years. But if you get to a point where your kidneys do fail completely, then you do only have a few weeks at best. And this is something that I'm a little old school. I know people want a lot of things in an app or whatever, but I in my practice, I actually print this out, laminate it, and give it to the fellows and show them this is how we might use this in our day-to-day practice of explaining to people what they could expect. And I'm thinking that I haven't incorporated this myself yet, but the heat maps might be really effective too, in terms of just giving people more of a picture rather than these percentages that don't really have a whole lot of meaning to the individual person. So kind of switching over to capacity, I wanted to get a sense of the audience, like what is your capacity? So do patients with end-stage kidney disease have access to outpatient palliative care where you are? Yes, is it embedded like within the nephrology clinic or the dialysis unit, or do they actually do home visits or something similar? Do they have access to it, but it's a separate clinic they'd have to go to? Or no, your patients just don't have access to outpatient palliative care?
So far, we've got 23%. Hold on. 23. Hold on. It's just waiting for a few more people to respond. Or it'll show me the. Okay. 26% said yes, they're a separate clinic. 5% yes, embedded. 23% no.
Okay. Okay. Well, I think in where I am, we are starting to have in that our palliative care folks will come to the dialysis unit, but mostly it's a separate clinic. And personally, in my own practice, I've only been able to justify it because the patient had another terminal illness in addition to kidney failure. Because right now they aren't including kidney failure patients. In California, there's a new law from Senate Bill 1004 that mandates Medicaid providers have to provide outpatient palliative care to people with serious illnesses, including end-stage lung, liver, heart disease, and cancer, but it doesn't include kidney failure, unfortunately. So this gets into the question of capacity. Even though that we know that palliative care consultation is a really positive thing, this is some of the some more results from the paper that I mentioned to you earlier in the talk about from the Palliative Care Quality Network, really showing, well, here on the right, the symptom improvement. It was significant from the first to second assessment in both the groups, a group with renal disease and other serious illness. And similarly, except particularly where anxiety was much more improved for the renal disease group. And here on the left, it shows the difference that the consultation made for just code status. These two bars are for the renal disease people at the initial consult versus discharge, who were full code versus do not resuscitate, do not intubate at discharge, and similarly for other serious illness. And as you can see, the decisions had pretty much flipped similarly between the two groups. But we do know that the capacity for palliative care and hospice are very limited. From editorials that I published last year, for palliative care, I'm going to get the acronym wrong, AAHPM, the American Association of Hospice and Palliative Care Medicine, I think that's right. They estimate that there's only one palliative care specialist for roughly every 20,000 adults with serious illness. And a study limited to just California found that only 20% of institutions had outpatient palliative care. And I think in practice, though, there are a handful of folks around the country who are both board certified in nephrology and palliative care. Oftentimes, our palliative care colleagues, even though this is not a dig, I love our palliative care colleagues and I think they're incredible, but sometimes they do lack the renal specificity of just knowing exactly what the special needs of our kidney failure patients might be. And similarly with hospice, hospice is particularly difficult because since it came out of this tradition of applying to patients with end-stage cancer who are ready to, to let go, dialysis doesn't really fit into that because it's often looked at as life prolonging. And as I mentioned earlier, applying to our Medicaid patients for outpatient palliative care, we have this federal rule that people cannot have hospice and the end-stage kidney disease benefit unless they have a disease, a terminal illness, in addition to kidney failure. And strangely enough, we allow the private healthcare insurers to determine if kidney failure is not the terminal illness before they'll decide to pay for both. So this becomes pretty critical because if the patients do not maintain that dual eligibility, then the hospice is on the hook for paying for everything, including dialysis. And with the kind of low stipend, daily stipend that they get, it doesn't fit within their budget. Similarly, they don't have on their formulary some of the mainstays of treatment for our patients, particularly the erythropoietin stimulating agents like Epogen or Aranes that they say it's because they're considered life prolonging, but I think, the other truth to that is that they're really expensive. And even though they offer plenty of other medications that could prolong a person's life, like antibiotics, for example, we know that these medications do make our patients actually feel better. So the last area that I'd like to cover, and I realize we're getting a little short on time.
Yeah. Vanessa, I'm sorry to interrupt, but we have about 5 or 6 questions piling up now, too.
Okay.
And I didn't know if you wanted to field some of them, or, the rest of your talk, how you want to handle it.
Let's see. I have a handful of other slides. Let's hear some of the questions.
Would you like me to tell you what the questions are, and then you can sort of decide how to handle it?
Yeah.
Okay. So one nurse asked, when do you discuss prognosis with regard to a time-limited trial? Before the trial, after the trial? Another question, which looks like it's referable to where you were about to go, is can you have dialysis and palliative care too? Another one said, what's the difference in the vertical lines in the best case, worst case? Why were the vertical lines different in length on the dialysis and the no dialysis options? And then just a question about Mrs. Lee. Knowing what you know now, if you could replay Mrs. Lee, how would you do it? And how would you train the upcoming generation of nephrology clinicians to be better prepared to take care of patients like Mrs. Lee?
Yeah, all great questions. I'll start at the top with Mrs. Lee. I think I do it very differently now. I would, granted, I have a lot more experience and a lot more knowledge, and that's something that I actively work to pass on to fellows, so hoping that they won't have such a heartbreaking experience. But I definitely would break out to her more of the things that I'm talking about in terms of, and the family, in terms of the best case, worst case. And that gets to the question about the, what the vertical lines meant. Let's see if I can I get back to that without, okay, yeah, here we go. So this, what this means is, so this is the best case, worst case. So it can, at the high end, it could be, you do really well, but at the worst case, it could be really bad. And based on what you know about the patient, this is where you expect them to be. And in this example, the clinician is suggesting that there's not that much a different range between what the best and the worst could look like, but still this oval here represents what they think is most likely for the patient. I hope that clarifies that one a bit. In terms of when do I discuss, or should a time-limited trial prognosis should be discussed, I think the answer is yes, all of the above. Definitely before you make the decision to start dialysis, and then these check-ins, you need to be talking about kind of what the prognosis is, what we've been able to achieve, what we haven't been achieved in terms of making the decision to if we're going to continue this or not. I'll talk about dialysis and palliative care bit next. So let me just go back. So, and this is what we wrote about. Woody is the second author on this paper, where we talk about a different approach to people who are already on dialysis. And this stems from, this figure stems from the dialysis, the palliative care literature in and of itself, where we go from, people have different levels of need throughout the course after starting dialysis. People may not need that much in terms of palliative care, and this is a switch from where our conventional approach of focusing on standard metrics to more of a patient-centered metric, focusing on symptoms and goals of care, particularly for people in that last year of life. I'm going to hustle a little bit And basically, this approach understands that there are good things about dialysis. For some people, it can extend their lives. I know that in-center hemo patients, they do have a sense of community, and it can provide some symptom relief in some cases, but it's not all good. Clearly, there's a lot of procedures to maintain access. People spend a lot of time in the hospital and they never quite get back to where they were, and dialysis itself can cause symptoms. So let's just take 30 seconds for this question. Which of the following is most consistent with a palliative approach to dialysis care? Keeping the patient on a statin, getting that minimum KT over V, not prescribing a binder for a phosphorus of 6, fistula first, catheter never, all of these or none of these? Let's cut this off in the interest of time. I know I only have a couple minutes, and there was...
None of the above is the highest response you got. 20%.
Well, actually, I was going for no binder for a phosphorus of 6, basically saying, you know, tolerate a little bit of imperfection to prevent the patient from having to swallow more pills. This is more detail of that. And when we could consider changing course is if life expectancy changes, like they develop a new illness, they have steady progressive decline. And I know Woody presented this in greater detail. If the answer to the surprise question is no, if you would not be surprised if the patient in front of you would die within the next year, then you need to be talking about these things. It might be less scary, a slower transition than just stopping dialysis altogether. And then this is the last question. I wanted to touch on what the elephant in the room is when it comes to decision making for older patients. Is it poverty? Is it race? Is it unaddressed symptoms? Is it access to hospice? I hope I'm not losing too many folks. I have like 2 minutes that I'll cut it down to. What did people think?
They're hanging in with you. You still have like 95% of the people you started with.
Woohoo! Thank you, guys. I'll try to make it worth your while. What did people say to this?
Sherry, do you have a response? You're on mute, Sherry. Maybe you should go on and she'll come back.
Well, I mean, this is a little bit of read my mind. I picked the answer as race, but I would also accept poverty. Oh, wow. People.
Yeah. Response is unaddressed symptoms, 24%, 20% access to hospice.
So what I'm getting at here in terms of the elephant in the room, the things that we rarely speak to, and we definitely need to take into account, is that these issues of race. And here's just a little cartoon to lighten the mood a tiny bit. I'm right there in the room, and no one even acknowledges me, the elephant on the couch talking to a therapist. And I think this is important to talk about because you know, this country, particularly around race, and you can say any other difference like sexual orientation, gender, religion, et cetera, has a long history of treating people unfairly based upon these differences. And in the U.S., this is a picture of the little lady. She was 99 at the time, and this is 4 generations of her family. She was the daughter of a slave, Ruth Bonner, who got to ring the bell for the new African-American Museum of History and Culture in D.C. back in 2016. And this is, of course, one of the young women integrating Little Rock High School in Arkansas back in '57, and these folks are in their 70s now and still voting. So I know with the current administration, I think nobody is thinking we're in a post-racial society, but just to point out that this is all fairly recent that we've even disrupted segregation. And these are just a couple pictures to show how prevalent and in your face a lot of the issues around race are now. And then I said I would also accept poverty as kind of like a second best answer. And just pointing out, this is, I'm sure most are familiar with Maslow's hierarchy of needs, but I just want to point out all this self-actualization. I call this more like privileged people's problems, thinking, what do I want to leave the world kind of thing, and basing decisions upon that. For myself at the county hospital, a lot of people are down here with basic needs around survival, and to talk to them about potentially foregoing something that might prolong their survival is a tough road to hoe. So my suggestion for how to deal with the elephant, I think we do have to call it out and we have to say something. And something that I've started using in my own practice that I haven't studied it, but I see anecdotal physical like relaxation, acceptance of what I say by saying, if you were my father, mother, whomever, or relative, with the caveat, a relative that I actually like, I would, that was supposed to be a joke, I would recommend the same. And so I think this kind of just puts it out there, takes it off the table, what people are really thinking. They have a lot of distrust of the medical system. They don't drop all of their stuff at the door when they walk inside. And this one kind of eases their minds that we're not just trying to kill them or make money off of them. I'm always surprised at how some people hold those two thoughts together, and that we would do the exact same thing, or we would recommend the exact same thing to somebody that we really care about. And a list of the things, how we might be able to do better. A lot of this is in one of the editorial I mentioned, but I want to point out these last two in terms of it's important for nephrologists to collaborate and not just delegate. What I mean by this is with our palliative care colleagues, we need to learn from them, not just kind of push all the tough conversations to them, so that we can do a better job of taking the lead on things when we don't have the capacity among palliative care specialists themselves. And then we need to grow our workforce. And by this, I mean 40% of our nephrology fellowship positions tend to go unfilled, and we need to attract more people to the field. So we need to make nephrology feel a lot more accessible, make it look a lot more attractive, so we can bring more folks in to help with this. And so I'll stop there and just leaving you with the thought to consider that the best path for the person in front of us may not be the one that's straight ahead.
Well, okay, Vanessa,
sorry.
Yeah, no, that was fantastic. I think we were successful in getting the questions answered. I don't see any more. Sherry has said that she will be sharing your slides in a few days, and I think we want to encourage people to make sure they complete the evaluation. If you have other things that you want to communicate to Vanessa, questions you want to ask, send them to Sherry, and she will get them to Vanessa. And I really want to thank people for their attention. This was really, I think, our best, most successful one yet in terms of attendance and questions. So I really hope that this group will come back again April 25th to hear Dr. Kukar talk about how to evaluate and manage depression in chronic kidney disease. Our goal is to do just what Dr. Grubbs was talking about, which is to continue to educate so that we'll all be better at taking care of our patients. And with that, Sherry, am I missing anything, or should we just thank them? Thank you very much for your participation.
I think you got it all. Thank you all for attending.
All right, and thank you again, Vanessa.
Thank you.
Bye-bye.
Bye. you.